This is going to be Critical Care Pharmacology Part 8, and this is going to be neuromuscular blocking agents. Neuromuscular blocking agents, they're used as adjuncts to facilitate intratracheal intubation. They pretty much paralyze the skeletal muscle, and the point on this is that your patient's LOC has not changed. So use with sedative agents, render the patient paralyzed, non-unconscious, is what these agents do. So whenever you put on board a paralytic, it's not going to stop them from remembering what you're doing to them. So be sure and knock down their level of consciousness as well. The use of things like Versed, etomidate can be used in conjunction with these, Diprovan, things like that. Depolarizing agents. We have two types of neuromuscular blocking agents. The depolarizing agent is one type, and this is going to be the only depolarizing agent we have, which is succinylcholine. Class skeletal muscle relaxant and depolarizing paralytic, blocks cholinergic receptor sites on the motor end plate, produces depolarization, and this is going to actually make your patient fasciculate, which means they're going to have erratic firing of the motor end plate. Inhibits subsequent nerve impulses and transmissions for the duration of the drug, and then achieves rapid onset and acts over the short term. Indications for this drug is going to be rapid sequence intubation. Contraindications: person or family history of malignant hyperthermia, skeletal muscle myopathies. Use cautiously in patients. In pediatrics, it takes a little bit more than it would in an adult. If they have burns, there can be complications, or if they're at any risk for hyperkalemia, because you're going to make them a little hyperkalemic. Succinylcholine side effects are respiratory paralysis, malignant hyperthermia, muscular fasciculations, rhabdomyolysis, increased intracranial pressure, intragastric and intraocular pressures. This thing has a lot of complications. Sux is not the best choice for every patient. It can be used. The complications, though, sometimes may outweigh the usage of this drug. Rhabdomyolysis, for those of you wondering what that is, breakdown of muscle fibers leads to the release of the contents or myoglobin in the blood, and this can cause complications. Myoglobin will clog up any filtering organ, kidneys, liver, spleen. Dosing on Sux is going to be 1 to 1.5 milligrams per kilogram IV. In the pediatric patient, like I said, you'll have to use a little more, 1 to 2 milligrams per kilogram IV. Special considerations: be prepared for endotracheal intubation immediately after administering the drug. When intubation is unsuccessful, ventilatory assistance is required. For the duration of this drug, they're not going to be able to initiate a respiration. Eye care to prevent desiccation and abrasions. Keeping their eyeball or their eyelid shut is going to be, if you allow their eyes to open, they can't blink during the duration of this drug. So eye care needs to be initiated on these patients. Shelf life of about 30 days after removal from the refrigerator. Non-depolarizing agents, and this is our other class, and there's several non-depolarizing agents out there. There is only one depolarizing agent. The difference between them, just a quick overview: Sux works on the motor end plate, so it stimulates this motor end plate, and it does this for about 10 to 15 minutes of duration, and it's going to cause action potentials to erratically fire. It cannot functionally work during the time frame of this drug, and this is depolarizing. The other version is a non-depolarizing, and what it's going to do is it's going to block this motor end plate. Most of these are curare alkaloids, so by blocking this, we can get a longer duration. Some of these paralytics, like Pavilon, will work up to 60 minutes, and this is non-depolarizing. So Vecuronium or Norcuron, class skeletal muscle relaxant, non-depolarizing neuromuscular blocking agent. Action: blocks cholinergic receptors on the motor end plate, does not result in muscle depolarization, achieves no fasciculations, inhibits nerve impulse transmissions. Indications: need for RSI or long-term paralysis after initiating a rapid sequence intubation. Contraindications: known hypersensitivity. Side effects similar to those of succinylcholine. It's going to paralyze your patient. No fasciculations will be seen with this. The reason we get fasciculations is because of the stimulating factor of the depolarizing paralytic. Dosing of Vecuronium or Norcuron, a defasciculating dose. Now, if we're trying to be politically correct or we're worried about the fasciculations causing an increase in ICP, we should probably defasciculate our patient, which means we're going to put on board a medication to where they're not going to fasciculate. And it's generally 10% of the dose of the long-term paralytic that you're going to use. Example of this, you're going to get about 30 minutes of downtime or paralyzation time with the Vecuronium. Defasciculating dose, if we'll look at the adult dose, which is at 0.1 milligrams per kilogram. %10 of that is going to be the defasciculating dose. Now, what that's going to do is that's going to cause no fasciculations. It will block the motor end plate. They will still become paralyzed, not off of the defasciculating dose, but off of the dose of succinylcholine, and we can facilitate intubation. Pardon. Okay, so defasciculating dose is 0.01 milligrams per kilogram IV. Paralyzing dose, 0.08 to 1 milligram per kilogram IV. Repeat in 20 to 45 minutes. For pediatrics, 0.1 milligram per kilogram IV, and repeat every 37 to 60 minutes. We need to assess the patient frequently. If it looks like they're coming out of the paralyzation, we need to retake them down if we want to still facilitate intubation. Special considerations: consider using sedatives or analgesics to decrease cardiovascular side effects. They can feel all the pain of intubation. Intubation is painful. For anybody that's ever had surgery and your throat's sore afterwards, there's a good example. The throat was sore from the facilitation of the intubation. Be prepared to endotracheally intubate immediately after administering the drug. When intubation is unsuccessful, you're going to have to ventilate your patient for about 20 to 45 minutes. Alternate airways should be on hand and handy so that you can switch to another airway type. Eye care to prevent desiccation and abrasions. Pancuronium, bromide, or Pavulon. Class on this is going to be skeletal muscle relaxant or neuromuscular blocking agent. Blocks cholinergic receptor sites on the motor end plate, does not result in muscle depolarization, achieves no fasciculations. This is also going to be a neuromuscular blocking agent, non-depolarizing. Compared to other neuromuscular blocking agents, provides very little histamine release, which means that we're not going to get a lot of vasodilation out of this. Imparts less bronchospasm and hypotension. Indications: need for rapid sequence intubation, long-term paralysis after RSI. Contraindications: if you have any hypersensitivity. Side effects similar to those of Vecuronium, greater cardiac effects though than Vecuronium, tachycardia, and we can generate some ventricular ectopy off of this drug. Dose on this, adult, 0.04 milligrams per kilo to 1.1 milligram per kilogram IV. Pediatric dose is the same as the adult. Special considerations: consider using sedative analgesics to decrease cardiovascular side effects. Be prepared for endotracheal intubation immediately after administering the drug. When intubation is unsuccessful, ventilatory assistance is required. Eye care to prevent desiccation and abrasions. And this is because they aren't going to be able to blink. Class on this is rocuronium bromide or Zimiron, another neuromuscular blocking agent. Class on this is skeletal muscle relaxant or non-depolarizing neuromuscular blocking agent. Actions: blocks cholinergic receptor sites on the motor end plate, does not result in muscle depolarization, achieves no fasciculations, inhibits nerve impulse transmissions, and this is another blocking agent. Indications for this is going to be the need for rapid sequence intubation, long-term paralysis after an induction or the use of sucks. Contraindication: known hypersensitivity. Side effects are going to be pretty much similar to those for Pancuronium. It will paralyze your patient. Fewer cardiovascular side effects are noted with this medication. Dose: adult for rapid sequence intubation is 0.6 milligrams per kilogram IV. Maintenance paralyzation: 0.1 to 0.2 milligrams per kilogram IV every 1 to 2 hours. Continuous infusion is going to be 0.01 to 0.012 milligrams per kilogram per minute, and that's going to be intravenous. Pediatrics greater than 2 years old is going to be 0.6 milligrams per kilogram IV. Special considerations: you are going to have to use sedation and analgesia in all of these neuromuscular blocking agents. It will decrease cardiovascular side effects because, again, they can feel and their brain's going to respond to the pain and the sensation of being intubated. Be prepared for endotracheal intubation immediately after administering the drug. When intubation is unsuccessful, ventilatory assistance is going to be required. You're going to paralyze them. Eye care to prevent desiccation and abrasions. Fascicurium bestolate or Nimbex. Class on this is going to be skeletal muscle relaxant, non-depolarizing neuromuscular blocking agent. Blocks cholinergic receptors on the motor end plate. As the actions on this does not result in muscle depolarization, achieves no fasciculations, and again, this whole depolarization of the end plate is what gives us the fasciculations. Inhibits nerve impulse transmissions. Has immediate onset and duration compared to other neuromuscular blocking agents. So if you're using a standalone neuromuscular blocking agent, non-depolarizing, to facilitate your intubation, Nimbex is going to be a pretty good choice. Indications: need for RSI or long-term paralysis after an RSI. Contraindications: known hypersensitivity. Side effects on this: bradycardia, hypotension, flushing, or bronchospasm can actually occur. Dose on this, on an adult, 0.15 milligrams per kilogram to 0.20 milligrams per kilogram IV. Maintenance infusion of 1 to 3 mics per kilogram per minute. Pediatrics less than 12 years old, 1 to 2 mics per kilogram per minute. Special considerations: use cautiously with patients in electrolyte abnormalities, burns, neuromuscular disease, advanced age, decreased renal function, and pregnancy. We can make the patient a little hyperkalemic with this medication. This ends Part 8. If you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smithr@emsa.net. Thank you.